Here. Welcome back to Rare Connection, the podcast that connects rare disease patients, educates medical professionals and public, and explores clinical trials and supportive care for conditions that often lack approved treatment. Today's episode explores a topic relevant to both rare diseases and cancer communities, palliative care, and how it is often misunderstood. My guest, Anne, is a licensed psychotherapist specializing in palliative care. She's also a breast cancer survivor and caregiver to her husband, who is living with metastatic prostate cancer. Anne is the clinic manager and palliative care social worker for the Motion Picture Television Fund, when she serves members of the entertainment industry. She brings a powerful perspective living and working with cancer 24/7, and she's here to help us better understand what palliative care really is, how it differs from hospice, why emotional support is critical throughout every phase of a serious illness. Now, please note this episode may touch on emotional and sensitive topics. If you or someone you know is struggling, resources are available in the show notes. And can you share your journey with from caregiver to cancer patient to palliative care therapist?
Yes. So, hi, welcome, or hello. Thank you for having me here today. It starts back when I've been in the field of psychotherapy, working in the hospital for over 30 years. And about 15 years ago, I transitioned to working in palliative care at the hospital. And then I transitioned to outpatient with the facility that I'm at now. And so I was working with palliative care, working with a lot of different diagnoses. When my husband was diagnosed with prostate cancer in 2019. And unfortunately, he was diagnosed with a pretty aggressive cancer that had already metastasized. So he was at stage 4, which was challenging for me because I have been working with such serious illnesses and poor prognosis at times, that when I got his diagnosis, my mind immediately went to the worst case scenario. So that was a pretty difficult time in 2019. He finished his cancer treatments in 2020, the day that Los Angeles, where we live, where that shut down due to COVID. So we sort of went through this very, scary and depressing, and we don't know how long he has to live, straight into COVID, where we're all kind of trapped into this small house with my emerging teenager, 18 and 19-year-old, and my dad, and we're here. So that was in 2020. In 2021, things started opening up, and I started going to my wellness care checkup. So I went to a mammogram, and I was found to have cancer too, with breast cancer. So then I received surgery, I was in radiation, and now I'm on medications. So it was sort of just this roller coaster of one thing after another. And what I think made it most challenging for me was because I work in palliative care, my mind just went to the worst case scenario and just one thing after another. So that was, I guess, it was an interesting challenge in terms of the timing.
What was it like facing your own diagnosis shortly after your husband's?
It was really hard because, like I said, I had in COVID, my daughter was graduating high school. So that was, really difficult for the seniors. And then transitioning to college, my son was in the first year of college. So getting the diagnosis just felt like one more slam on the family. Like, how could I even tell these people, my family, what is happening to me? Because it just started the whole trauma of my husband getting cancer all over again. So my diagnosis is stage 1, and it was, really good treatments, and they seem like they've gotten it. But knowing what I know from my job, it's like I always worry, the doctors will say one thing, it doesn't mean that that's accurate. Nobody has a crystal ball. So it's been an emotional journey.
How did the pandemic affect your personal and professional life during that time?
Excuse me. It affected it because when COVID first hit, when the social isolation started, we just jumped immediately to online. I work in an outpatient facility, but it's on the campus of a skilled nursing and assisted living. So one of the patients contracted COVID, and so it was just like, get out, everybody that doesn't need to be here needs to leave. So when I eventually went back to my desk, I realized I had even left my Diet Coke on the desk for a year. So it was very quick, get out. And we transitioned to Zoom very quickly, which was good because we were able to serve our patients and help them through the trying times. But emotionally at home with my dad had come out to help my husband. He's in his 80s. He can't go back home because we're worried about him living alone and going on the air, the plane. And then with my kids at home, it was just a lot of emotion, and then trying to hold space for my patients who really were scared too. I had one patient that she was in her 90s. Her husband was in a skilled nursing rehab, and she wasn't able to see him. He was on the first floor, so she got a ladder, and this 90-year-old lady was climbing up a ladder to be able to see her husband through the window. And so it was just a lot of trauma and grief for a lot of people. So it was trying to hold space for that as well as my family.
A lot of people have to travel across state or country even to go see a physician. So it's they really need to keep the telehealth.
It was really hard. A lot of our patients would be in the hospital or making end of life decisions, should they stay on a ventilator? Should they start dialysis? When is it time for hospice? And you're having these conversations on Zoom where it's just very real and scary for people. And nobody quite knew how to work Zoom. And so there's just so much emotions in the country and the world, and just seeing people in an already vulnerable state. It was really sad. It was a lot.
So what is palliative care, and how does it differ from hospice?
So palliative care is kind of misunderstood. A lot of times doctors will say, oh, things should go palliative, or maybe palliative care is needed. If you look at palliative care as sort of a broad scope of care, it's anything from the beginning of a diagnosis straight through to end of life, and then even bereavement. And so hospice is sort of that end point where a doctor, for better or worse, says, if without curative focused treatments, you may have 6 months or longer to live. And so it's based through a Medicare guideline. If you have a prognosis of 6 months or longer, sometimes people are on hospice several years, but just in our best guess that they're reaching the end of life, that's where hospice is. And hospice provides a really good resource in terms of a social work, chaplain, nursing, really good pain management, doctor support. So it was a really good model to give holistic support. But what we were finding in the medical system is we're doing this great job in the last 6 months or so of a person's life, but all the same stressors were happening for people who are trying to navigate finances, childcare, work issues, pain, and symptoms from their treatments. So why are we providing this great care at end of life when so many people are living with serious, life-limiting, life-altering diseases? Why are we not giving that? So palliative care emerged as a distinct discipline from hospice. So like I said, it's all kind of one continuum, but the pre-hospice palliative care is where I mostly work. And that's where we really want to catch people early when they have a new diagnosis, when it's scary. A lot of times they have emotional or existential concerns in addition to the physical. sometimes, especially with rare diseases, you're bouncing from specialist to doctor to doctor to doctor, getting a lot of different information from a lot of different people. And it's scary. And it's like, who do I trust? Who do I turn to? So palliative care is a really good resource for helping people be having a sounding board, having a place to discuss their fears, their just what's going to go next, who is going to be making decisions if, God forbid, you couldn't make decisions for yourself, and just finding a place to process, like, how do I make sense of this? How do I make meaning of a really critical situation, and how do I not lose my sense of self? And that's what I find a lot of people feel like. You go into the doctor and you're just a bunch of numbers. What's your vitals? What's your numbers? Has your disease escalated or whatever? And they become a patient rather than remembering we're people. We have a whole life. We have families. We have work. We have things that we love to do. And where do I lose that personhood in the medical system? So palliative care kind of draws back and says, whoa, let's start with who you are as a person, what's important to you, what's valuable to you. And then based on that, how can we get you the right information and give you a space to be seen, to be heard, to be able to express what, was really scary.
It sounds a lot like social work in some ways.
Yeah, with palliative care, we have a full team in the best model. Sometimes there's hybrid models, but the palliative care is usually a provider, like a physician or nurse practitioner, a social worker, like what I do, a chaplain, and a nurse who provides symptom support and education. And so we all work in our own ways to provide holistic care. What I found with some of my patients is they come in like, I have severe pain, nausea, I can barely get out of bed. And the doctor does his thing and talks about medication and what we can do. And then there's sort of a pause in the room. So myself and the chaplain say, hey, what's going on emotionally? And then there's, breakdown or, tears or talking about anxiety and fears. And then by the end of the session, we had one person that said, my pain is better. Like, I don't know what you guys did, but I'm feeling better. I can get out of bed. I feel like I can get out of bed and do some things. And I felt like that's really what serious illness is. It's not just physical. There's that whole emotional part. And when we feel emotionally better, we tend to feel physically better. It doesn't take all of it away, but it can definitely help. And also sometimes when you're feeling sad or having difficult emotions, we realize that there's some physical symptoms that people are dealing with that haven't been addressed. So it kind of goes hand in hand, where we all sort of, I think of it like wormholes, like we start one place and then we wind up somewhere else. So I guess that's what we do.
Why do you think so many people still misunderstand this distinction?
I think that there's just a misconception in the medical system, either from patients. You hear, you hear from people, oh, I had palliative care and then my dad died, a few weeks later, or physicians like oncologists will say there's no curative treatment, but we can give you palliative treatment, meaning you're not going to be cured, but you could live a longer life because you're getting treatments that will keep you comfortable. So there's a lot of misconception in terms of what the word is. And then, so a lot of people confuse palliative care and hospice as being the same thing. And then in the outpatient setting, a lot of times people get a referral for hospice and they are like, I'm not dying. I don't want to talk about that. I want to maintain hope. So then people will say, well, let's refer you to palliative. But people kind of, see that as the same thing. Or the doctors will say, let's get you palliative for more support. And then the company might have palliative care and hospice. So it's it just kind of gets confused, and it's scary when you're in a serious condition. We always go to the worst case. Like, I have stage 1 breast cancer, but when they said you have cancer, I'm like, I'm going to die tomorrow, or how much time do I have? With my husband, it's even more serious. We live kind of day to day, month to month. So it's like your worst case is already in the back of your mind, that I'm going to die. So any words that come out that you need, more support, or that it's related to, if you have the flu, you're not going to be getting palliative care. So, it's a serious issue. And so I think people just kind of, their emotions get the best of them.
So, how can rare disease patients benefit from early palliative care, even when their disease is not terminal?
Well, I think that's a really important part. And most of my colleagues in palliative care agree that we get referrals too late in the system, where the crisis is already occurring. But if we can get people early on, we get to know them when they're still active, when they're still feeling better, when they can speak for themselves and talk about what's important, so that we can build a relationship. So if things change, then we already say, we've had this conversation. We've talked about the what ifs if something, changes, or we have to make critical decisions. We've made them already, so let's revisit those. So I sort of think it as, strike while the iron is cold, where we're not in an emergency. My boss likes to say that when we're in a critical situation, like, the disease is really advanced, it's like a fire that's out of control. And if you have a tiny Dixie cup and pour water on the fire, it's not going to change it. But if you start early and it's a little birthday candle with a fire, and you have a Dixie cup, you pour water on it, it's going to take the fire away. So we really want to catch people where we can develop a relationship. We can get to know what the symptoms are. And a lot of times there's things that we can talk about, either emotionally, spiritually, existentially, and physically, to help kind of contain some of these things, so people don't live so long with that discomfort. With my husband, he was after radiation, he has prostate cancer, and he had a lot of bowel issues, way beyond the radiation, like a lot of damage there, a lot of burning. And so he's having really bad issues with his bowel movements. And we just thought, well, it's part of the disease. What can you do? It's just permanent damage. And when he started working with the palliative care physician, he was like, no, we got stuff. We can do some different things. And so with adjusting medications, different things, his bowel movements got a lot better. So it was just about having a specialist that says, let's look at the bigger picture. Let's look at your quality of life, what's important to you, so that we can try to make your life easier.
Yeah, I work as a caregiver, and the hospice is normally only 6 months. So if you go back, and you're normally kicked off after 6 months if you're still alive.
Right.
So would they go back to palliative on that? Mm-hmm. Or
yes, definitely. I have people that sort of bounce back, and we have patients, for example, like dementia or cognitive issues. Sometimes it's hard to say this is the line in the sand where you have 6 months or less. So doctors may say, well, you kind of qualify for hospice, but then the symptoms get managed. There's, more of a back to baseline or a steady point. And so our patients will be referred back to palliative care, where we have that ongoing monitoring. With hospice, you have like somebody coming in weekly to your home and having medications delivered, having a hospital bed or equipment, having 24-hour nursing support. If something happens, you immediately have somebody that can problem solve or come over. But with palliative care, it's not as intense like that. Usually it's like monthly visits or check-ins during business hours. So it's more of a outpatient, or even if it's in home, it's a check-in kind of thing. So it's definitely less support. So if people need hospice at end of life, that obviously is better. But if a person's stabilized and they don't need that intensity, palliative care is a great resource for observing and monitoring and still being there to help problem solve and provide all that other support.
Yeah. You talked about anticipatory grief, panic, and profound sadness. How do you help patients and work through these emotions?
Yeah, I think again, it's always important for me and for my team to look at the person as a human being and as a family. I consider every patient, the family is the patient, not just the not just the person going through the illness. And so starting off is that we see you. A lot of times we say we have a 70% cry rate at the first visit because people are just going to doctor's appointments. You have 15 minutes, they're just sitting there typing, not really looking at you or taking a pause to say, how are you feeling? So it's just really hard. People feel really isolated. So when they come to palliative care and we say, we see you, we care about you, we want to walk this journey with you, you're not alone, it really breaks down the barrier of we just see the tears or a sigh of relief that, wow, nobody's talked to me this way. So some part of it is palliative care being present for people with those emotions and asking questions. And then it's providing space to talk about it, whether it's the patient or the caregiver or family member, to talk about their fears. Sometimes we see that there's a trajectory that we know things are probably going to go in a certain direction. Like with ALS, there's definitely markers where we know things are going to get worse and probably as they're getting worse. So kind of inching at those discussions, like, we're worried about things changing. We're worried about needing to make decisions. How do you feel about that? So that people aren't caught by surprise when they're in a crisis. So being able to talk about things when they're not in a crisis, then the emotions come up, the existential or spiritual questioning comes up, and then we sit there and be with them. And a lot of times I provide validation that you're not crazy. This is normal, what you're going through. A lot of times people, especially with rare diseases, when people don't know, you're going to a lot of appointments, you're going to a lot of specialists, and it's really scary. So helping people kind of understand the medical trauma associated with that when you're poked and prodded and talking about your mortality or living with something very serious, that has forever altered your functioning, just helping people understand that this is a normal process. And whether it's, the validation, sometimes people are triggered by this stuff with old things. If I have a history of trauma in my life, abuse, or just really poor support system, or issues in my personal life, then an illness is going to trigger all those old things. So making sure that people kind of have a place to talk about things emotionally. And sometimes it's processing in a way like sometimes we refer to psychotherapy if a person needs something more intense, or just, like I said, having a place to talk.
So what does emerging caregiver mean in your book contribution? And how does that identity affect you?
Yeah, so I was asked to participate in an anthology for caregivers, and I consider myself as sort of an emerging caregiver for my husband, and also my father's aging. My mother's across the country, so I am doing a little bit with her, not as much. But I sort of see it as, and talking about an emerging caregiver, the people that I care for are still very independent. My husband's working. He's, lives an active life. You probably wouldn't know that he was sick, but there's just things that I'm thinking ahead for him that, especially with my work or when I talk to the doctors, there are things that I know that if things get worse, how are the hospitalizations going to be treated? Are there things that we can ask about symptom management? being prepared for the future. And when I think of myself as emerging, it's sort of like a few steps ahead of my husband, that he doesn't need the day-to-day care right now, but he needs somebody to listen at the doctor's appointments, to think ahead, to help get the advanced healthcare directive in place, things like that. And with my father, his balance is a little bit off. So making sure that he's asking the questions to the doctor about how do I maintain safety? He has bars in his bathroom now, things like that. So it's just a different set of eyes. And then with my patients, as the condition progresses, I'm sure the caregiver, just gets more and more involved, whether it's driving people, taking care of the day-to-day in the household to make sure they're okay. And then it emerges to personal care, helping people with, dressing or bathing or those kind of things. And so I think it's sort of a continuum. And for caregivers, it's really important to make sure that they have the resources and support, because it is going to be a long journey for most people. And so realizing they're not alone, kind of knowing there's a map ahead of them, and that being able to talk about fears and hear other people that might be further along the process where their loved one needs more things, that, that they've got some tricks up their sleeve. So I guess right now I see myself as things are going to get harder, and I want to plan for that and be there in this role, knowing that I'm not going to sit on the sidelines, that, well, it's his, my husband's problem or my dad's problem, they'll figure it out. It's like, I want to be involved so I know I can be prepared for the future.
How can professionals avoid burnout while living in close proximity to both personally and professionally?
Yeah, that's the trick question there. A lot of times when I interview people, like I have interns and things, we ask that and they say, well, I walk my dog, or, I, eat the right foods, or I talk to friends, and all those things are important. My personal self-care is that I sort of put a guardrail up in terms of what I listen to. It's very hard in these challenging times to listen to a lot of news. It's hard for me to see suffering. So I have to cut that out. I've sort of become a Hallmark junkie where I listen to good things, predictable things, so I'm not caught by surprise. So I know there's a happy ending. So that helps me a lot. And then with my situation where my husband was sick, COVID hit, my kids were sort of in crisis, and then I got cancer, I sort of bottomed out. Like, it was just like, how much more can I take? And I started a writing practice. I started going to a writing group, which I consider sort of a support group. It's sort of a learning support group. And I was able to just write out a lot of my emotions and be in a class where other people listen and hear me. And that was an outlet for me. I have other friends that have developed hobbies that have helped them really have a practice outside. Like my husband teaches meditation, mindfulness meditation. And he does daily, sitting, doing meditation. He talks to other people, has a community where he can practice with them and do retreats and things. So it's finding what's important to you outside of your work, putting boundaries around, like with me, it's hard because now we're working a lot at home, knowing when to close the door and not looking at the emails, or if you hear the phone ring, just not going in there, but really having the boundaries. And I think for caregivers, it's really hard for people to find that time when the care needs are so high. But even just being able to go out and drink a cup of coffee in the other room, or, be out in nature a little bit, I think that helps. So I think professional, what I'm doing, and then also family caregiving, it's kind of all the same thing, but it's really about protecting your heart. The other thing I guess I would say is really keeping up on top of your medical appointments. If I hadn't done my mammogram, then there's no way I would have found my cancer. There was no lump. There was a lump, but I couldn't feel it. And it only came through through the imaging. And I hear a lot of times from my coworkers, it's just, I have so much to do. I'm working late. I don't have time to go to the appointments. Or the caregivers that I work with, that it's just my body's second priority. And then things catch up with you, and we can get into more difficult situations. So it's finding what's right for your person.
Definitely run into that a lot.
Yeah.
Yeah, and a lot of people, their spouse is the only one that cares for them.
Yeah.
So.
Yeah. And the other part, I think, is that I don't know about your listeners, about you, but for me, it's really hard to ask for help. It's like, as a professional, I'm supposed to be the one that helps other people, and to realize that I need to ask for help too. When I had my my husband's going all through this stuff, and then I get surgery and my radiation, it was really difficult. I didn't want to ask anybody for help, and my boss just said, we're setting up a meal train. And I'm like, I'm not totally incapacitated, but she did it, and people were bringing food over or giving us gift cards or whatever, and it was so meaningful to me, that I didn't have to make a decision. That I was in pain, I couldn't get off the couch, somebody else was caring for me. And sometimes I notice with my dad, he never wants to ask. He wants to take the bus to appointments and things. And sometimes I just say, Dad, I'll drive you. Like, just let me make your life a little bit easier. But I think in our culture, it's really hard to ask for help. And it takes the burden off when we know that other people are there to support us. So part of it is being willing to accept help, being willing to be a receiver. And givers want to do that. They find meaning and joy in being able to give something to others. So when we ask for help, it allows them to do a kindness. And for me, it's learning to sit with that it's okay to be vulnerable.
My job, that I work out of the home, and there's nobody else to ask. And so it's not kind of a situation. I just got to break away occasionally. A lot of times I run around situations, grocery shopping or something.
Well, I'll tell you, and then one thing that I do, to your point, is I facilitate caregiver support groups and patient support groups, which I think is really important when you feel alone and isolated and you basically don't have a lot of options in terms of taking a break. It's really important to connect with other people so that you hear, just connecting and hearing other people's stories helps you. It's like a balm that just takes the stress off a little. So part of my, I do the groups monthly, so that's part of my job.
Steve, what does your role at the Motion Picture Television Fund look like day-to-day?
Typical day in my outpatient clinic is we have a schedule of patients, and then we sort of go back to back where patients and families come in. We see them with the whole team. So we have the physician, the nurse, the chaplain, and me, the social work psychotherapist. We're all there in the same room to hear what's going on. And sometimes there's follow-ups, like somebody will have a lot of physical needs, and then the doctor's changing medication. So the nurse follow-up will be checking to see if the medications are working, if there's problems associated with it. And then people will talk about, like, the caregiver burnout. So then I'm on the non-clinic days, I'm following up with families to make sure they have caregiving resources, caregiving support, and for the patient that they have the social support. Sometimes there's financial issues or insurance issues and things. So helping point people in the right direction of how to get their questions answered. And then also just a place to problem solve. Like, I have patients that are in the hospital, and so on the off days from clinic, I'll talk to them about what the discharge plan is going to be. If you go home, what that's going to look like. If you need placement and you can't afford it, what are the options there? Or skilled nursing rehab for short term, like really trying to problem solve in between, and then just providing emotional space for support.
Can you tell us about your TikTok blog Anne Front at Anne Front LMFT and how you how you use that to raise awareness?
Yeah, so I have a TikTok blog. I call myself the palliative care therapist. And what I found with my job is that I say the same things over and over again to people individually, and there's no medical guideline for how to help people with serious illness. Everybody's kind of figuring it out for themselves and trying to get information here or there, but there's no place where people talk about hard things in a consistent manner. So I felt like I keep saying the same things. I talk about caregiving, coping skills for when a person's going through a serious illness, what to plan for, things like that. And I felt like maybe I should do this on a bigger level because people need answers, and sometimes they need answers that they don't even know what the questions are for. So I started doing these little TikToks, or about a minute, a couple minutes, just on different topics. And that's been really, I think, useful for people. One person said to me, I found you just the right time that I needed you. I had another patient that called me for an intake, and he said, I need information about palliative care and hospice. And it was like a Friday. And then I get these emails back and forth with the patient and the whole family, like showing my TikToks on the email. And then when I called them Monday, they said, oh, your TikToks already covered the questions that I had. So it just felt kind of validating that having a place for information to be out there on a larger scale for people that don't have access to palliative care right now or hospice, that they can get answers. So that's been kind of a nice thing, I think, with that project.
What do you wish more people, especially medical professionals, understood about palliative care?
I think what's come to me from working in palliative care, with working with serious illness, and then with my husband and myself having cancer, what I've realized is that it's such an emotional journey, and we don't address that enough. And so as professionals, being aware that when the person's in the room talking about pain, talking about the future, talking about other symptoms, talking about treatment, options, it's an emotional journey. And so being able to stop for a few minutes and say, how are you feeling? How are you taking in this news? How's your family coping with this? How are you doing with work? Asking questions that are outside of the medical symptoms brings it back to, the whole person that people are. And most people can solve their own problems. They can figure it out. You can get bad news and you find a way to cope with that. But when you don't have the information or your questions answered, or you feel alone, it just gets so overwhelming. So for professionals, I say try to stop and give some space for that time. And then for patients and caregivers, I feel that it's really important to acknowledge that part, because a lot of times people want to skip over that. I don't have time to think about it. I don't have time to cry. I just have to do this job. I have to get through, muscle through the treatments and get to the different specialists. And I don't want to talk about feelings, but the feelings keep bubbling up. And so it's important to say, you got to have space for that, because at some point you're going to get into an emotional or existential crisis that's going to make your physical part so much worse. So really, realizing it's an emotional journey and finding space for that, finding a way to release that and to find ways to help cope with that. One last thing to suggest is that if you have questions about palliative care, if you think that it would be beneficial, talk to your physician. And if they push back and they say, you're not at end of life, you're nowhere near that, you don't need it, just push back and say palliative care is for any stage. It's extra support. And if you still have a struggle, I would look into local palliative care programs in your area and ask them to give you information about how they can be helpful or if it's an appropriate service for them so that they can help advocate for you. There's a website in America, getpalliativecare.org, and you can put in your zip code or your information, and then it'll show you where the local providers are.
And thank you for being so open with your story and for helping us better understand the vital role of palliative care, and not just for end of life support, but for empowering, compassionate, and resource for those navigating serious illness. For our viewers and listeners, please subscribe to Reconnection on your favorite podcast app, and to my YouTube channel, Rare Chef, where you can catch the live video version of this episode. If you're watching on YouTube, drop a comment below. If you're listening on audio, you can text me directly through the link in the show notes. And don't forget to follow Reconnection on Facebook, LinkedIn, and X. If you or someone you love is struggling emotionally, help is available. Call or text 988 for the Suicide and Crisis Lifeline, or text HOME to 741-741 to reach the crisis text line. And remember, you are not alone. We are all part of this Reconnection.